This is a meeting.
You got a quorum. You got Rex McKinney's on there.
Okay,
So you have a
we're
quorum.
ready to begin. This is a meeting of the Executive Committee of the State Department of Health. And we do not yet have a quorum.
How we do?
However, we will go ahead with the meeting and another member may join.
Right, you have a quorum.
Okay, thank you. We do have a quorum. Therefore, I'm calling the meeting to order. Okay, there is a quorum present now. I'll ask if any board members have any known conflicts of interest to disclose. Seeing none, we'll proceed with the meeting. You have before you the minutes of May 14th, 2025.
Can we go ahead and read this before we, got to read this before we?
Yeah, yes, we have to read the announcements.
Okay. So please be advised that this is a public meeting in accordance with open door law that is being live streamed to the public and recorded. The recording will be archived and available to the public for no less than 90 days. By attending and participating in this meeting, you acknowledge and consent to the live streaming and recording of the meeting, including your image, voice, and any contributions you make.
Okay.
We will once again address the minutes of May 14th, 2025. Are there any comments from the board members? Any corrections? If not, I will entertain a motion for approval.
I would move to approve the minutes. Second?
I have it's been moved and seconded that we approve the minutes. That needs to be a roll call vote. So, Steve Tharp, yes.
Brenda Goff, yes. Robin Marks, yes. Joanne Martin, yes.
Armando Soto, yes.
And, well,
Holly Robinson,
Holly,
yes.
for you to say it.
Holly Robinson, yes.
And,
He's on the wrong link. You might not be able to unmute. He's on the wrong link.
I can't read that.
Yeah, he's on the wrong link. Rex is on the wrong link.
Okay.
He can put something into Q&A and say approved or yay.
Okay. Rex, if you can hear me adequately, if you go to the Q&A, you can put your vote into there and because of the connection that you have. And I presume if he is unable to respond to us, that we can count that as, well, that we didn't get a vote. So, but I think we'll go ahead and accept that as an abstention for the
Okay.
moment. And, so the minutes are accepted by a majority. And then the next item on the agenda will be the secretary's report.
We're gonna have to come back to that one.
Sorry.
Come back to that one.
Okay. We'll come back to that one. The next item would be the Public Health Protection Commission amendment to Civil Penalties Rule 410 IAC 7-23. This is for discussion only, but we'll hear from
I am not Megan Weigel.
You're Kelly.
Megan is out today, so I'm Kelly McKinnon, and I'm the Chief Legal Counsel here at the department, so I will be presenting the rules in place today. So our first rule is updates to the civil penalties rule for the food code. So if you remember last year, you all, passed the updated version of the food code. At that time, we didn't, update the civil penalties. So there were new things added in that rule. It changed, sort of, how the food rule works. So there are things in that rule that don't have a corresponding civil penalty now. Part of the reason we delayed that was to give people implementation time, so they would learn the process before they would be available for any kind of fines at the local level. So we had delayed this piece of it for that reason. So now we're coming before you with the updated version of the civil penalties to correspond to those new things that are in that rule update. So we have Jordan here from the program if you have any specific or interim direction. So if you have any questions about this.
And this is posted online or not?
The documents are posted online.
Yeah, right.
Yeah.
Since this is an open meeting.
Yes, so the documents are posted on our website. You have any questions about this one? Any thoughts? We're very early in the process with this one. We still have to submit it to OMB and start all that process, but we want your feedback from you.
I do have a question, and that is, what is the timeline for correcting before the civil penalties are imposed? And there is a timeline, but it's not in the document.
So our current compliance enforcement process is we cite the violation, we then go back for a follow-up if it's warranted, if the criticality is severe enough. And then we document that again if we continue seeing that issue. And then once we get to a second repeat violation or the third consecutive inspection with that, we would and then go into our compliance enforcement process, which then warning letters to the business to let them know that they're operating in violation of state law and they need to correct those issues. And then we go back to do another follow-up. And then at that point, if they're still not correcting that issue, we would then look at compliance enforcement options like civil penalties or going in front of a judge to maybe get court mandated corrective actions. So there's an extensive process that leads up to the civil penalty. It's kind of a last resort.
So could you give kind of just, it looks like there's different levels of severity of the non-compliance.
Mm-hmm.
So just ballpark figures, are we talking about weeks, months?
Could be weeks, depends on the severity of the violation itself. It could be days, depending on what they see. I mean, depending on the circumstances, inspection to inspection, things could get worse, they could get better. And so it's kind of up to the judgment of the inspector on site to determine what next steps should be taken.
Is the authority to close down in severe situations? What, if you have a really, I mean, there's some that are really horrendous. So can you, without going through this drag it out thing, is there an action that can be taken in a very quick fashion, like pull the license immediately or something? I mean, I know those situations are not common at all, but still, is there the ability to do that?
Yes, we do. So in situations where we're under violations so severe that there is an imminent health hazard to the public, we have cease and desist orders in place that we can implement to kind of fly past the civil penalties. We just shut them down immediately until they get the necessary corrections in place. But like you said, very, very limited circumstances. That doesn't happen very often.
Any other questions? I don't see any questions in the chat. So, we will not be voting on this, today. We'll come back, for our final vote at another meeting.
Yes.
And, we'll go ahead, and, the listener.
Well, I think
Commissioner Williams.
you
want to go ahead and do the other?
Okay, or do you want to?
No, go ahead. You just want to go ahead with the next rule. Is that okay if she does?
Yeah, I just wanted
Yeah.
to give you the opportunity.
I think this should be quick. So.
Yeah, no, go ahead.
So this is, our, lead-based paint rule. So this is a program that we, implement on behalf of the EPA. So, they recently updated some of their own rules with different standards and things. So this rule update is to bring it into compliance with the EPA rules. And, so, this is something that's required for us to have the federal standards, at least the minimum federal standards, to be able to operate the program, for this at the state level. So that's what this rule does. Any Katie's here from the lead program.
Good morning, everyone.
Good morning.
There's only one thing that, we noticed that we wanted to make sure we understood. And that is that now, if it's detectable at all, does that just mean that there is lead present, or does that, it looks like there's other sections that say what level we have to take action. But I know that, at least one of, our board members, along with me, wasn't real sure what the implications of just saying if it's present at all.
So if it is present at the levels that the EPA standard is and our new code changes that, then, it does not get cleared for, being, but at state levels with lead, I should say. Does not mean that there's no lead, because it would be zero at that time, and that's pretty much impossible to do. But they're saying that if it reads at that level or lower, then it's safe to inhabit the home. Did that answer your question?
Yeah, it didn't,
So
it didn't sound like it said.
So there's the changes where it just says, like, from, it used to say.
Yeah, so it says.
So like if there's,
10 milligrams, you can take 10 milligrams, per square foot for the floors. Now they've reduced it to 5 micrograms, I'm sorry, not milligrams.
Yeah.
And then they reduced it to 5. And like window sills, it was 100 micrograms per square foot, now it's 40. And, window troughs are for 400 micrograms, and now it's 100. So they've decreased it quite a bit.
and I think there was some in definitions and things though, where it mentions, it just has if it's detectable.
Right.
Like that's what they're asking about, is where it says it's detectable. So what that change means.
I don't, if it's detectable, it is, I'm not sure what the question is, but it reaches that standard, right? So if it's detectable, it is at that standard or higher. And so they have to clear it, clean it, get it out. So it is at that lower level or below.
Yeah, it's on the second page of our handout.
Okay,
And it's the, third section, and then they've crossed out, threshold set forth by the United States EPA, and it's a detectable level of lead. But that, what you're saying is that actually means, at the action level.
you were exceeding the detectable level, where exactly.
Okay.
You can make sure that that's clear.
Yeah, yeah, well, no, we are
Make a
just going
clarification.
over it the first time, so we'll be sure everybody understands.
Detectable probably. I think we just have to look at definitions and things to make sure that.
Yeah,
I think we need to define detectable level, what that means, so that we can add that in.
Detectable level for
You're
the
thinking
specific
it should say
area.
action level.
You're thinking it should say action level as opposed to detectable?
Something
Well,
like that. Detectable means anything, right? It doesn't
Right.
specify a number, it means even like, 1 microgram. So we just need to make sure it's clear as to the levels that require action. But you do have on the next page, good catch for you guys. It does say any detectable amount of lead. Is that what that is? Is it still actionable level, not any detectable? For lead contaminated stuff, for dash. Section 48. Let's just go back and look at those and make sure that we're
We'll
clear.
make sure we get those,
Great.
so that they're clear. Thank you.
Okay, are there any other, questions, from, board members or, public individuals? public individuals that are online can, put a question in the, text, to us, if, they do have a question they'd like to have answered. Give them a moment if somebody does. Can't get that in.
Well, that's even,
Okay, so we're not gonna vote on this,
Right,
we're
we
not
will need
voting
to,
on this.
we'll change that.
So,
when we submit it,
This will be
we
coming back to us.
submit back here.
And, with that, we'll move on to, the commissioners report.
Yes, good morning, everybody. Thank you for being here. Just a couple quick updates for me, and then I know we have some amazing presentations. We'll leave plenty of time for that. Just Health First Indiana update. We're still working with our health department, preparing for the decrease in funding in 26 and 27, what that will look like. And again, just really hoping to help them narrow to their areas of the greatest need. And the teams are working diligently right now on making pretty simple, out of the box, highly evidence-based, have a good return on investment program to address, several areas. Like, for example, infant mortality, right? What's something that they could do to really just lay out the steps? One of the toolkits or playbooks or whatever you want to call it, be around coalition building. Now is more the time than ever before where we need our private partners to step up, because unfortunately some really good programs that the local health departments have started to implement, they're at risk of needing to walk away from because of the funding changes. And so in those cases, we'll need to maybe have some businesses or other private foundations, whatever that may look like, come to the table. And again, this really should be a community plan. Just in general, also with Health First Indiana, I don't remember if I shared last time, but Pam did announce her retirement. She is retiring in September. She is unfortunately out on extended medical leave right now. And so we're thankful that Dr. Crowder is helping oversee those teams, but then she will retire. So hopefully she'll be able to come back and say goodbye to you guys, and you can join us in thanking her for her 35 years of service. This was her first job coming out of college. She's been here ever since. I think we've already talked to you guys last time, had updated you on the federal funding cuts. We had some other federal grants that we had not received notice of award of, but then right at the end of June, beginning of July, we did receive those notices of award. So we are in a better place than we thought we were even just a couple of weeks ago, in maintaining the work and program that we do here. But as we're discussing with the team, we're going to continue to have to evaluate all things in the Department of Health, and probably will be needing to make some hard decisions in the future. But we're okay from now. We're just looking for, some efficiencies across different groups, and programs across the Department of Health. And again, just a focus on not so much of like the nice to haves and do's, but really what do we have to do? What is the role of the agency for the state, and what's the role of local health departments and healthcare sector, et cetera, et cetera. So that work will continue. We do now have launched our dashboard of all dashboards. Can you pull that up, Andy, please?
Well,
This has been a long dream. I mean, I'll just say personally for me, but I hope shared across our agency and with our partners. Just amazing how we have been able to accelerate our ability to get data in a usable fashion to our partners and stakeholders across the state. And so we now have this public health data navigator, which sounds better than the dashboard of all dashboards, but it does put all of our data in one place. So if you are, in Knox County and you want to know what's going on in Knox County when it comes to, what data is out there and available, you can come to this dashboard and for this one place and just see all the different data that we have. It also includes our reports. There's lots of reports that we have to report on every single year. So you just put it in one single location. So you can see here, of course, HFI is up here, our core services, maternal and child health, which I know Eden will talk to you guys about chronic disease and, a lot of these, almost all of them now, dashboards are interactive. So for example, our cancer dashboard, no, it's like super sensitive. There we go. You can interchange different, things to be able to narrow in and get the data that you want. So infectious disease, lead, entomology, if you want to see what's going on with mosquitoes right now, or tick-borne illnesses, it's all there. Isn't it amazing? I'm so excited, so thankful to our data team, to all the individual, divisions who put in the work for this, and of course, public affairs, and Greta, who helped with the design. So it is there and ready for everybody to use. Okay, stop sharing. Okay. And then lastly, the 39th annual Indiana Health Fair is coming up next week, Thursday through Sunday. We are going to do all the things that we've always done before, but it is also the WNBA All-Star Weekend. So we're going to be having a ladies' night on Friday night to focus on women's health. Amazing panel of women will be talking about different aspects of women's health care. They're going to do a Zumba demonstration, and it's sponsored by the WNBA. So we're excited that these fun things are happening this weekend to bring more people to go. But a one stick with community, hosted by community, for people to check hemoglobin A1C, hyperlipidemia. People can also get their prostate levels checked. You can do, they have like oral health things there. They'll have, Anson always says from your feet to your head. So podiatry, of course, all of our different divisions. Lead will be there talking about lead hazards. Our fatality review team that our moms and baby division will be there talking about safe sleep. We have tons of sponsors and about $4,000 worth of free screenings for Hoosiers. Yeah. Super, super excited about that. So it's Thursday through Sunday. It is free, open to the public, of course. So if you know anybody who utilize that, come and check it out. And it's fun. If, cooking demonstrations, etc. Also, we've had some changes in the agency, and I'd like to introduce you to Jessica Cruz. Hi, there you are. She's going to be, or she is, as of Monday. As of Monday, our new assistant commissioner over regulatory. Yeah, so we stole her from the Medicaid fraud unit. And so she does have background, and it's just jumped right in. It's going to do an amazing job for us. Do you want to tell them a little bit more about you?
Sure. So I worked at as you said, AG's office for the past 13 years in the Medicaid fraud control unit, so working in that healthcare space. On a different aspect of it, but generally familiar. Did some licensing work with them as well, enforcement on medical licenses, healthcare licenses. So that kept me pretty busy. Prior to that, I worked as a staff attorney at the Department of Child Services for about 5 years. So I've worked for the state of Indiana basically for my entire professional career that I've been in Indiana. So just bounced around to a couple agencies, but not very quickly. And I was born in Muncie, but then moved around a whole bunch. So I am a native Hoosier and have been here for a long time. So I'm happy to be serving in this role now.
Happy to have you. Yeah, lifelong public servant, and just going to do a great job. Thank you. Any questions for Jessica? Why are you looking at me? I have a list of things to talk about. Michelle Shippey, who's also here, is our new executive director of our Healthy Hoosiers Foundation. You want to tell them a little bit about you and your background and some of the exciting things we're talking about in our Healthy Hoosiers Foundation, speaking of foundations and businesses. But yeah, go ahead.
Yeah, absolutely. So I have worked public health my entire career. I have 16 years at the Marion County Public Health Department. I'm a dietitian, so I've been in chronic disease and food access world majority of the time. And I have a lot of experience in federal grants specifically. I've been awarded a number of them at Marion County. I was sitting in the Division of Nutrition and Physical Activity for about 1.5 years until Monday was my first official day as the executive director for the Healthy Hoosier Foundation. And yeah, I think
to your point of really leveraging private dollars and building some relationships and partnerships across the state, with a lot of uncertainties, I think it's going to be really important. So I'm excited to do that and see where it goes. Thank you.
Thank you. And then lastly, lots of changes at the Department of Health. Also would like to announce that, my chief of staff, is leaving. Amy is, last day, next Friday. I've only cried 15 times, it's okay. And so just really excited. She's still gonna be serving, Indiana just in a different way and still, the health space as well. So we're excited. This is an amazing opportunity for her family. And we will be sad, to see her go, but we're also really excited for her. So thank you, Amy. You want to tell them all the things that you have done?
Oh my gosh. I mean, I can't say all the things I've done, but I think what I am proudest of is just getting to watch the people in this agency and the incredible change and evolution that we've gone through in public health since I came in December of 2017, right after Dr. Box came in, and the progress in infant mortality, in lead, and like all the things that just felt insurmountable, and how much we've accomplished, and how much Indiana is better for it. This agency is better for it. So it's a hard decision to leave state government. I've also been a lifelong public servant since I graduated from IU, but I'm excited for this next new chapter. I'll be cheering on the department from the outside private sector and excited to still work in the health space and continue to advocate for the health of Hoosiers, which is, my passion, my purpose that gets me up every day. So.
And so with that, John, is the new chief of staff. Keep on moving. And we are actively interviewing for, the chief operating officer position to backfill John's position. So, we'll be looking to do an internal candidate with that. And, like I said, we're in general kind of looking across the agency to, make some updates and some changes. So very excited. John, as you guys probably know, is amazing and is going to easily jump into Amy's shoes. So I think that is the end of my goodbyes and hellos. Thank you.
Okay, thank you very much.
Can I ask for a clarification? At our last meeting, you were reporting that the Help First Indiana funding went from 150 million per year, decreased to 40 million per year.
That's right.
Is it still at 40 million, or is there a?
Yeah, that was the
I just wanted to be sure it didn't go down anymore.
That's right. Yeah. No, and it they get that funding January 1.
Okay.
So they're in their 150 million year right now, and it'll go down to 40. Yeah.
Because that has just made such a huge improvement in public health availability of essential services at the local level. We just hate to see that.
Great way. We're going to continue to look at the progress that we've made and those improvements, and we're still talking to legislators and have had many indications that this is something to revisit. So this is not, this wasn't we unfortunately just had a very significant budget shortfall this year, and hard decisions had to be made. But that doesn't mean that things won't change in the future. Yeah.
Thank you very much. Next on the agenda is, Children Families Commission update on the infant mortality rate.
Eden, it's easy. It's been a while since I've been in front of you guys. But nice to see you all again. As mentioned, I'm the Assistant Commissioner for Women, Children, and Families. And definitely want to introduce you to Rose. Rose, have you been in front of this group before? Rose Douglas is our Maternal and Child Health Director. So I split up the spot, and Rose came in as the new MCH Director back in September. So lots to learn and lots to do, but we do have exciting updates to report. So I want to pass the torch over to Rose to share. Great. Thank you all so much. Like Eden said, I'm Rose Douglas. I'm the Maternal Child Health Director.
So we're going to share a little bit about our preliminary 2024 infant mortality data with you. May just have to advance it down there in the bottom left corner. Loud mouth. Deal with it. Just to go over a little bit about how we calculate our rate, our preliminary 2024 data is based on our death records from 2024. So these could be births that took place in 2023 or 2024, and pregnancies that took place in 22 or 23. So we calculate our infant mortality rate by taking the number of infant deaths divided by the total number of live births for the given calendar year, and then that rate is expressed per 1,000 live births. So we collect our infant mortality data through our vital records division and our birth outcome data. And we calculate infant mortality based on residency rather than location of occurrence. So if an Indiana resident experienced an infant death outside of the state, we're still going to receive that data and incorporate it into our rate. That's okay, there's not many slides. So as you can see, over the last 10 years, we've calculated our rate. We've had some peaks and valleys, but I'm happy to share that our preliminary 2024 data shows us at a rate of 6.3, which we have not seen in the entirety of our data collection time. So going back to the year 1900. Our 2024 data is really exciting. Like I said, it's our lowest rate in over 100 years. So we attribute that to a number of things. First, our strong partnerships with local communities through Health First Indiana, our home visiting agencies, our FEMA teams, our weight clinics, and others. In our MCH division, we rely on health promotion and primary prevention programming. So again, through home visiting programs, through our Title V investments, our safety pin grant investments, and many others. Our sister agency, the Division of Family Health Data and Fatality Prevention, we rely on them for their fatality review and their prevention programming. Our EPIs and our friends in ODA and Vital Records, we rely on them for accurate and timely data so that we can calculate these rates in a quarterly preliminary fashion. And our women, children, and families clinical team is focused on quality improvement, training, and risk-appropriate care in the clinical space. So how do we keep that momentum going? We continue to focus our efforts on the highest causes of infant and maternal mortality. We craft data-driven goals that ensure that fewer Hoosier babies are born too small and too early. And we recognize that healthy babies come from healthy pregnancies, come from healthy bodies. And our role is to make the healthy path the easy one through early prenatal care access, smoking cessation, breastfeeding and mental health support, food access, and others.
I have a few questions. One is, when you look at the reduction in the mortality rate, are you able to, or will you break it down between neonatal mortality and post-neonatal mortality?
Yeah. So when we dive into our data, we always separate it by specific age, so that neonatal up to 28 days and then everything beyond.
So right now, you don't know where the improvement has been.
I think we do,
Do
just
you?
not in this presentation. So I can find that out.
Yeah, and the other thing is, have you broken it down yet by race and ethnicity and maybe even maternal age?
Yeah, so for infant mortality, our larger data set is always stratified by race and ethnicity, by county, by birthing hospital, so we can really drive down to the zip code level of where these deaths are happening and who they're happening.
That's great. And because I think it's going to be really important, I don't know if you could break it down by Medicaid, first, because roughly 40% of all births are paid for by Medicaid. And so when those changes hit, which will be delayed a bit, we want to make sure that we're able to track that impact.
And we receive our Medicaid reports from our FSSA partners as well, so we can really get that deeper dive into who we're seeing these events and birth outcomes happen to. And if you visit our birth outcomes and infant mortality dashboard, you can see all of our birth outcomes are separated, again, by county, by HFI region. So we're looking at low birth weight, preterm birth, smoking, not breastfeeding, moms on Medicaid, teen births, and then the overall birth rate as well.
That's all available on the website. And we have a linked data PowerPoint presentation that is like 100 slides that links all that data that you're asking about. We just don't have it for 24 yet.
Right.
Yeah, we have for 23, but we don't have it for 24 yet.
Because the thing is, trying to figure out, okay, it's great that it went down,
But we're at.
why did it?
Yeah.
And if it bounces back up, why?
So historically, it is perinatal risk. So,
I know.
all the things that make moms unhealthy and at higher risk is the primary driver. But there's really good information in there, like smoking, so high risk.
I know.
Like, is it 20%? I think it's close to 20% of babies who die had a mom who smoked. So it's like, and because we know it's not just, the preterm baby, but it's also, higher risk of suicides, right? If there's someone smoking in the home. So, yeah. And that's what the team uses to drive, but we'll dig into the 24 data to really see if we can kind of narrow in, but just looking at the past, it's always in that perinatal risk area where we see it really moves the needle. And it's about 16 babies-ish. I know we're not really supposed to say that is, we're able to make it to their first birthday this year. So that's, to me, that's a lot of babies, but also that's a number you can grab a hold on. So all these counties doing this work, if they just help one mom, one baby make it to their first birthday, it moves the needle on that number. Yeah.
How do they compare to other states with this? We've proved our track record here. How are we relative to other states? If everybody else sort of improved the same amount, are we in the same? I know we're not in pole position, but where were we, roughly?
Yeah, I think with it being preliminary, that's still something we're yet to determine. We're roughly consistent with some of our neighbors. So yeah, I'm excited once we get our full 2024 data set to see how it's improved across the region.
And then we're dependent on the other states to release numbers. Really good song. Fine. Because the team has worked so hard to get this information out earlier, a lot of other states are not with us. Some of them are.
We can't make
the comparison yet, yeah. And I think honestly, the last comparison isn't even 23, was it? Or was it 22? Or did we do but that doesn't, trust me, I'm like getting on Ohio's website. What did they say for prelim? What did Michigan say for prelim? So we haven't really seen, we should be proud of this decrease. Yeah.
For sure.
Yeah.
I think that's the other win from this too, is our preliminary data release, whereas we've had to wait so long for a previous year's IMR. The fact that we have a preliminary data for 2024 in the first part of 2025 is something we really haven't been able to brag about. And that's kudos to investments in our infrastructure, our data science team, our vital records team, really new processes. So this slide is a result of a year's worth of work and partnership and collaboration across the agency to make this happen. So 2 wins here, I think, on this slide to be proud of.
The reason I always look at infant mortality is it's probably the most sensitive indicator of the general health of the population.
It is the number one indicator.
It is the number one indicator. And so, you know, it might seem like, well, that's just such a small piece, but it just really is reflective of a lot of what's going on in communities.
Any other questions? If not, we'll move on to the update on youth tobacco. Miranda.
Well, good morning. I'm Miranda Spitznagel, Division Director for Tobacco Prevention Cessation. I also want to introduce my colleague, Caitlin Rupp, our Director for Program Evaluation. Caitlin and her team are really instrumental in all the information I'm about to share with respect to our youth tobacco survey and some of those key findings. A few things about the youth tobacco survey as I start. We've been collecting this data since 2000. We collected on the even years in the fall. We've been, modernizing our way that we do data collection for many years. The last 3 survey cycles have been online survey administration. And back in the day, we were just doing paper and pencil. So the team has really been able to evolve the way we collect the data and the ability to get that in quickly. We surveyed middle schools and high schools. And it really is the gold standard of youth tobacco use for the state and asking data about knowledge, attitudes, beliefs, obviously behaviors, how youth understand tobacco use, what they think about the products as well. So really proud of the foundation and the history and the work that our team has put into this for some time. So I'm really going to give you some high level. Again, we also have a 100 slide deck. We're not going to show that today. But high level. So I'm going to talk quickly about every use, current use of tobacco, maybe some areas that we're seeing some concern, and then just interest in quitting among our young people as well. So quickly, every use of all tobacco products. Again, you can see this broken down in middle school or high school use. Just a quick illustration, 1 in 10 middle school students, 1 in 5 high school students have ever tried a tobacco product. This chart gives you a breakdown of the type of product that they report ever trying or ever using. The blue bars are middle school, green bars are high school, and you can see e-cigarette use is among the highest. And then nicotine pouches we're seeing in our high school use specifically. And as a result, this is a significant finding that we've seen from 2022 to 24 is really a doubling in ever use of these nicotine pouches. What these are. So it's a little tin, lightly flavored, various levels of nicotine concentration. And so that's, again, a new emerging product that we're paying attention to. So let me point that out. Current use. So again, just a quick illustration of middle school use versus high school use. And then specifically by product type. So again, seeing that current use of e-cigarettes is among the highest use of products in particular. Again, you're seeing those nicotine pouches for high school use as well. Let me define current use. So that's use of at least 1 time in the past 30 days. How we define that. And then this is how we compare to the rest of the country. So the United States data are from the National Youth Tobacco Survey, also collected in 2024. And you can see that Indiana is trending a little bit lower than the national data. So this is something to celebrate, something we're celebrating. If you look at where we started when we started collecting cigarette smoking data back in 2000, we had 32% of our high school youth reporting current use. We are now down to less than 1% among our high school youth. Similar trend for middle school youth, well exceeding the target that we set for our 2025 strategic plan. So really something I think we can celebrate here in Indiana. Yeah. A couple comments about trends. Again, we look at these data over time. Youth who are smoking cigarettes or smoking fewer cigarettes, using them less frequently. One thing we're noticing though is just monitoring age of initiation. So first use, by the age of 15 has kind of ticked back up. So it's something I think that we'll monitor, I think, into the future for cigarette smoking. The first tobacco product that young people end up trying, you can see here very strongly, 2/3 are reporting e-cigarettes. So that's usually the first product of initiation for our young people. Also trends, also something to celebrate with trends in our e-cigarette or vaping use among our middle high school youth. So we started asking these data in 2012. We saw in those over, 6 years, almost 300% increase in those rates that we reported in 2018, which prompted a lot of our work and efforts under the Vape for Indiana initiative. We're now down to, again, 5% for high school youth, 2.4 for middle school youth. Again, really something to celebrate those dramatic reductions and also exceeding our target that we set in our 25. An area of concern, however, is just the frequency of e-cigarette use among those young people who are using products. So we just define that as use on 20 in the last 30 days. Again, for middle school youth, about 20%, for high school youth, 45%, again, can classify in that frequent e-cigarette use. As we look at some changes over time, again, that frequent use is a concern. And then about 2/3 of young people who are using e-cigarettes started before the age of 15. We asked on the survey, what are your reasons for trying an e-cigarette or vaping device? You can see there's some differences for middle school and high school. Again, it's a lot of a friend is using them or feeling anxious or stressed, depressed, again, trying to use something like that or try something like that as a coping mechanism. Flavors is another reason we see a lot, other people using them. So again, just trying to peel back another layer to understand a little bit more about why young people are seeking out this type of a product. We also asked a lot of questions about, are there other types of substances other than nicotine? Because we know that there's some trends in this direction. And again, just trying to get a sense of what this looks like. And again, a good portion are also using other products. Most reported here would be marijuana, THC, or something related to that. Trends with susceptibility. So this is an important measure in our area of work, again, to kind of really monitor future likelihood of someone trying a tobacco product and becoming a lifelong, someone's addicted long term. Susceptibility is a couple different responses to questions. You can see them right there at the bottom, but it's essentially, do you think you're going to try cigarettes soon or maybe the next year? Would you try something if a friend offered it to you? And in 2024, we're about 1 in 4 of middle school and high school youth are susceptible. So these are young people who have never tried a cigarette, but are susceptible to perhaps trying in the future. That is gone up a little bit. If you look to the trend data, about 2010, 2012, we were down 15% of that. And so we're really kind of going in the wrong direction as it relates to this measure. And so again, something I think we're concerned with and we'll monitor.
When you say susceptible to smoking, but they've never smoked,
Right.
what is the definition of that?
Yeah, so it's a few things, a combination of responses to questions. So it's like, do you think you might, so that, how they answer positively that they might try in the next year,
okay.
that they might, and again, it's one of those scales where they have to have the response of like, I would never try something in order to be not susceptible. So, again, combination of things, but
Thank you.
just a way for us to see what's happening. A little bit on advertising and marketing. We also asked about, other questions.
Did you, this question is about susceptibilities and ask this relationship to marijuana?
We did ask them questions related to susceptibility in 2024, and we can follow up with the susceptibility rate for marijuana use. It's a little bit lower than cigarette use. We also asked them for e-cigarettes. So we can follow up with those Right.
I'm just curious.
Yeah, good question.
Relevant to that, bring the two.
I was wondering, is there any difference between girls and boys?
I think it depends on the product and what you're talking about. We do have some data specifically by gender. Is there something in particular,
Well,
susceptibility in particular?
No, I had been thinking about that, as you presented all of it, I think historically there've been differences, but I don't know if that's still the case.
Mainly with smokeless tobacco, so we see more male students using smokeless tobacco and nicotine pouches than female students, and that's really the only statistically significant difference by
But
gender.
there's not a difference in tobacco use versus not tobacco use.
Not overall and not specific to cigarette smoking, but, among students that responded that they currently or have ever tried cigarettes, we had such a low number that it's hard to suss out any demographic differences within that pool. So we're looking at tobacco use over time mostly. And then when it comes to those like smokeless tobacco products, smokeless tobacco and then nicotine pouches, there is somewhat of a dramatic difference that we can say is statistically significant. And that has been historically true for smokeless tobacco.
How big is your sample?
I don't have that. Do you know off the top of your head? At middle school and high school sample.
Oh, the middle school and high school sample for the survey?
Yeah.
So we it's a randomly drawn sample that's stratified for the entire state. We oversample for racial and ethnic minorities. And we have a sample of 120 schools, 60 middle schools and 60 high schools. And so because we oversample for racial and ethnic minorities to make sure that we can suss out those demographic differences when we are able to, we tend to have most of our sample in the more populous counties with urban centers. But we do sample, about, I would say 50% of our sample is in those like higher populous counties, larger schools, and then the rest are spread throughout the fairly rural communities as well.
For the school, how many classes are you? I mean, just to kind of ballpark numbers, it's 120 schools.
Yeah, so I can tell you the number of students that responded. It's an average, based on the size of the school. We randomly select classes within that school. So there's a 2-stage random sampling. It's the school and then the classes that get randomly sampled as well. And the larger the school, the more classes are selected. So it's an average of like 4 to 6 classes per school. But I can say that we have complete surveys from about 3,000 high school students and about 2,000 middle school students throughout the state.
Very good.
Yep. And we have demographics of the sample as well. We can send that out and follow up if you're interested.
Thank you.
Yeah.
Good question.
Just a couple other key findings. So exposure to tobacco marketing is highly connected to initiation and continued use of tobacco use. All of us, including young people, are seeing these advertisements in our communities all over the place. This is just one quick chart to be able to illustrate sort of the places in which young people are seeing types of advertisements. So these are among those who are currently using a tobacco product. Is the first set of bars. The second set of bars are those who are currently using an e-cigarette or vaping device. Again, by middle school and high school, a lot of advertisements in stores in particular that you see convenience stores, gas stations, a lot of that advertising present. But then specifically TV and movies, streaming services, again, I think this is interestingly that it's so high among our middle school youth who are using products. This, built on a long time knowledge base that the exposure to this types of imagery, advertisements, do link to initiation. Flavored products. So again, you can pretty much get any type of tobacco product in any type of flavor that you like. And a lot of those who are using products on regularly are using flavor products. So again, 3/4 of high school use and more than half are middle school use. So it's really an influencer in young people starting to use the products and then continuing to use them. The bright spots on interest in quitting. So, this is again quick illustration of middle school and high school youth who have made a quit attempt. Again, this is among everyone using tobacco, any type of tobacco product, so interest in quitting is high. And this is specifically sourced among those using e-cigarettes for vaping devices. Also, interest is high. However, when we ask, what have you used to help you quit? So many of our young people are really just trying to go it alone, not using any resource. This could be a teenage thing. This could be obviously a charge to us to make sure that they know of resources available, whether that be, services that we're offering and promoting through the state, from the school-based, and really encouraging to try to train up our providers as well, that they can talk to their patients about some of these services also. So I think this is a challenge for us to figure out the more as we can get some of these resources in front of our young people. The encouraging thing is that they recognize that they want to change that behavior or want to stop. So, and I believe, just quickly, Dr.
Yeah, on the category of, school program, do the school programs notify parents of the utilization?
I think that's up to the school policy. It is very likely, I'm assuming, again, as a parent, that they're going to be.
It looks pretty low, but I assume that a lot of people don't want to do it because the parents are going to find out.
But, yeah. A couple different ways. Again, there's programs in which would include concern involvement, and I think that's a part of probably what a school offers. There's a lot of free text-based services out there. We promote Live Vape Free. There's also the X program from the Truth Initiative that young people can text specifically directly and get access to services. So there's a couple different options. And again, I think we want to make sure we've got a variety of tools to continue to be made available.
Some of the school programs are the students and parents are actually made to do because, for example, the student gets caught vaping in the bathroom in order to avoid suspension or some other things, and they do a school program. So I don't think that question spreads out between, I just let the school know I want to quit and they're helping me versus something happened and now I'm doing a program to help. Yeah. Which we actually encourage as programs. We like the avoiding of the bad behavior instead of pushing them, and instead encourage them to go towards a quit behavior right now.
Yeah, we really want to encourage alternative suspension and other supportive discipline options within schools, and are doing a lot to support schools in setting them.
Yeah, I basically wanted to ask if the school programs are at a disadvantage because they have to report back to parents or whoever, and so nobody's willing to do it because they know they're going to get reported back.
Yes. Again, just to wrap up some of the things we talked about, so really significant declines in use, tobacco use and e-cigarette use in particular. We know that young people want to quit, so we're encouraged by that. And then, we continue to be concerned, I think, about the evolving marketplace, new products coming on the market, flavors in particular, and then just the products that are out there, the level of concentration of nicotine in the products is certainly concerning. So we'll end there, and then a lot of the work that we've been doing and a lot of resources that we've been sharing, well, specifically as it relates to vaping, is on Vape Training on the website. So wanted to share that as well. So thanks for your discussion. Happy to take any more questions or see if there's anything else.
Has the increasing cost of cigarettes been identified as a particularly useful deterrent?
Yes. Yes. If you had to pick one thing, there are a lot of strategies and a lot of approaches that we've worked to implement, but that is a significant, raising the price is a significant strategy to reduce.
And that went into effect on July 1, with the $2 cigarette tax. I have a woman that I work with in the ER who is a smoker and told me her cigarette tax was $13
For a pack of cigarettes?
for a pack of cigarettes. Yep.
That's worked in other
Oh, yeah.
states that have done that. So it'd be really interesting to see if that kind of comes up as a reason to quit. And the other part, I think sometimes it gives people a face-saving way of saying, well, I'm just not going to pay that.
Right. So we know our calls to the Indiana Tobacco Quit Line, Indiana Resource doubled in the first week of July from the normal week. So we know that there's interest, and we're here to support with that.
We get the packs of cigarette sold data too, don't we?
We do, yeah, so we'll be able to monitor cigarette consumption over time as well. The last time we had a tax increase, which was 2007, we saw a 26% decline in consumption within that first year. So we'll monitor that and can report back.
Are you seeing any trend or shift in the use of nicotine to marijuana?
We are, I mean, there's a lot of co-use. I don't know if that's necessarily a shift. I think that's hard to determine, that there's
Or at least
co-use of the products. Certainly have been monitoring some data as it relates to marijuana use as well.
Well, they can vape marijuana, THC, and so they were showing some data that shows that they can decrease people utilizing it in that way. We have a slide on co-use to follow up with that as well. Thank you for your question. Thank you.
Thank you very much. Nellie. Welcome.
of oral health. And I'm so thankful and excited to share the oral health updates with you all. I'll start with our mission and vision, which is to promote, protect the safety of all the Hoosiers, regardless of their work, where they work, in live or play. Starting with why oral health matters. The tooth decay is the #1 chronic disease in the US. It is more prevalent than asthma or obesity. It is chronic. It is infectious, but it is preventable. And over 2 million people in US children, they reach or they visit the ER each year for this preventable tooth decay. Early childhood caries, which is also known as baby bottle caries, is severe. It is rapidly progressing tooth decay in infants and young children. Pregnant women with untreated oral infections, they face higher risk of preterm birth and low birth weight. Some diseases, they have shown to increase risk of heart disease, stroke, diabetes, Alzheimer's, and many other diseases, which have been recent studies which are associated with tooth decay. So now about Division of Oral Health. How does Division of Oral Health work? Division of Oral Health works in collaboration with our external partners and internal partners. External partners are the Indiana University School of Dentistry, the Indiana Dental Association, the Indiana Dental Hygiene Association, the Indiana Dental Licensing Agency, the State Association Territorial Dental Division Directors, the local health departments, the school nurses, the PTA, the community organizations, along with all the internal partners, the divisions within our IDOH, whom we collaborate with to promote oral health within the state. Oral disease that affects nearly 3.5 billion people across the US. 1 in 5 Indiana kids, 6 to 8 years of age, they have untreated tooth decay. Billions of dollars are spent each year in productivity for this untreated oral disease. $1 in prevention is equivalent to $50, which is saved in the emergency dental care. Around 3.6 million Hoosiers live in dental health professional shortage area, which is around 53% of the Indiana population. Only 5 local health departments in the state have oral health programs. And 3 counties, this is according to a recent data which has been received by the Global Center, 3 counties in the state, as compared to 1 county till last year, have no dentist or no hygienist in the state. Too many children, they fall through the cracks. Child may be screened in various counties, but will not get screening in various counties. Oral health should not depend on outside forces. So what success looks like in Indiana? Imagine in Indiana, where every child can smile without pain. We are able to detect dental tissues early and improve long-term outcomes. We can boost attendance. According to new data, 34 million 4-hours are lost each year due to the dental pain. We can prevent costly dental emergency visits and reduce gaps by reaching underserved students. I'm excited to share the strides we have made in the oral health department. to promote prevention, education, and access to care. So starting with Who Should Gives Us My program. This is an annual volunteer program, which happens in the country since 2003. Within the Department of Health, Oral Health Division, started this program 3 years back to increase access to care and promote health education. We engaged the community partners, the schools, the dental professionals, the community organizations, and created educational videos, the Game of Healthy Choices, which were distributed to aid to decide among the schools for oral health education. We were able to help educational events and screenings in the dental van, along with the School of Dentistry and the Marion County Health Department in the Central Library for the past 2 years, and distributed around 10,000 educational books to 10 Indiana libraries, which were shortlisted and got into the reduced school lunches, and we participated in partnership with Delta Dental Foundation and America's Trust Bank. We also facilitated services valued at $50,000 via HealthLink and Indiana University School of Dentistry, and we were able to sign 30 pediatric officers with a total of 116 pediatric providers for oral health care. Indiana is ranked #1 nationally for the past 3 consecutive years for ordering the most dental kits from America Dental Association. This year, the Who Should Give Kids a Smile program was held at the Children's Museum along with the School of Dentistry and the Marion County Health Department. The number increased to 51,000 dental kits, which were ordered by America's Dental Association, 13,000 dispatchers who reached out to us from the schools and local health departments were distributed to them. 90 children were screened and 100 additional were provided with educational materials. IDOH has distributed around 4,000 plus of additional dental kits this year only till now. This is a bar graph showing the number of kits, which we can see a substantial increase from the 2023 till 2025. This is a graph by the counties, the number of counties which increased from 2023 to 2024, and a substantial increase this year. Another milestone which the Oral Health Division reached was the production and distribution of the first ever Braille oral health books. These books were made and distributed to visually impaired preschools, and they were made accessible to the Central Library. I also served as a member of the WIPS Professional Advisory Group, and we were able to develop resources for the visually impaired community. There was no Braille book which were existing. So I reached out to Delta Dental Foundation. They realized the importance of that, and they funded the Macmillan, and now the Happy Teeth book is there, which is available in the whole country for people to have. Another accomplishment is that along with the Division of Nutrition and Physical Activity, we were able to get a CDC grant. We made a Super Smile, a dental health adventure curriculum for K to 12. K to 2 and 3 to 5 is already published. 6 to 9 and 9 to 12 is in work. So this curriculum, besides teaching about oral health to the children, about how to brush, how to floss, what is plaque, what is cavity, how to prevent, we are also including, in addition to that, about food guards, to wear helmets, the food drinks, the importance of that, what are oral care things, what is the dental fashionable things people want to have their on-sticks at dental drills, what is oil pulling, is it really effective? So what is HPV vaccination, should you have it? About vaping, body cigarettes. So trying to make this curriculum a holistic curriculum for our kids in the state of Indiana to know about oral health and how important it is to our overall health. A preventable tragedy, which happened in Maryland. A 12-year boy lost his life because infection from the tooth led to his death. Why? Because it was not detected earlier. Tooth decay is preventable. This should not happen. A child should never lose his life to a tooth decay. So in order to combat that, the state of Indiana took an initiative to train our school nurses and non-dental professionals about the basic screening, the children basic oral health screening. So this screenings, these are the visual screenings. They do not replace the dental screenings by a dentist, or we do not take x-rays, just the visual screening to detect the caries early, and so that the child can be referred to the dentist well in time. And we were able to submit a poster presentation in the Indiana School Network Health Conference this past month to reach out to the majority of our school nurses in the state. We were able to train around 100 plus school nurses and emergency preparedness staff. The last slide is our emergency prepared staff in action who are working, going into the health fairs and providing screenings to the kids in need. And we are distributing dental kits to the children who need that. Shifting gears to APA task force. The APA task force, via this, it's an access practice agreement. Via this agreement, a dental hygienist can work in the state without the presence of a dentist. It was passed, the law was passed in 2018. But till now, very few dentists and hygienists are in contract under this agreement. It could provide increased access to care in the state. Oral Health Division helped start the APA Care Task Force and involved the Indiana Dental Hygiene Association, the Indiana Dental Association, got everyone on board, and they which were able to make a survey, which was distributed throughout the state to the dental providers, make them learn, and they are helping these dentists and dental hygienists to have a contract and make it an easier process for them to get into this agreement. We were also able to buy the grant to reform dental book services to expand access to dental care with children in St. Joseph County through the school program. This is a virtual dental school with 10 dental hygienists to send out screenings, tele-dentistry, and preventive services in the school setting, as well as care for patients who will never be able to see a dentist in a traditional setting. So these hygienists, they basically operate under the APAs with the dentist providing telehealth services. There are 7 elementary schools which are participating in the School of Vishwaso. Around 2,800 kids are enrolled in the school. Union County collaboration. Till last year, Union County was the only county in the state without a dentist and a hygienist. It has increased to 3 this year. So we were able to collaborate with the School of Industry, Dr. Soto, students DY2 and 3, who are able to go to the Union County on a regular basis to provide screening and preventive services to everyone, not just kids, but to everyone living in that county and in helping them with their oral health needs. Healthy Smiles, Healthy Family, MCH Oral Health Initiative. And another initiative we took in collaboration with the School of Dentistry and Windrose Health Network. This is for the pregnant women to educate them about the importance of oral health, to let them know that oral health is safe during any trimester of pregnancy. They can get the x-rays done, they can go visit and get the dental treatment done during any trimester. So Dr. Soto and myself, we were able to visit the Windrose Health Center. We were able to look around the different rooms they showed us, and we were able to identify this one room, which was near to the waiting area for the pregnant females out there, and have easy access to the restroom. So we were able to identify this room, and now this room is being converted into a dental clinic. We are trying to get the equipment done, and hopefully in the coming months, we should be able to start the dental clinic in that Windrose Health Center. Outreach events. The Oral Health Department is involved in various outreach events along with the School of Dentistry and Marion County Health Dental Bank. We visited or took part in the visually impaired preschool Halloween event, the Immigration Center Health Fair, the Fiesta de Familia event, Asian Creole Resource Fair, back to school events, went for a presentation to give to the pregnant females in these maternal child health unit, provided them with the dental care, gave them information about what is good for them and their children. Indiana School of Blind, giving hands-on training to the children in the Indiana School of Blind about how to brush and floss their teeth, and many more events. Fascinating dental services. This is a program for the individuals with disabilities who are 65 years and above and medically compromised. It was established in 1991 with the support of Indiana Dental Association, and around 6,000 patients have been served through this program, and $20 million in total care donated by the volunteers. It's a statewide volunteer network which involves 446 dentists and 99 labs. And the last fiscal year, 243 patients were served, receiving treatment worth $752,000. The further initiatives, what we have taken in the Department of Health is We made flyers on monkeypox, measles, and distributed to the dental providers in the state. We collaborated with the Division of Tobacco Prevention, Cessation, Chronic Disease, IU Simon Center, Cancer Consortium to make tobacco cessation toolkits for the dental providers. We also made flyers for community water fluoridation and oral cancer self-screening staff for the public. We are partnering with infectious disease teams to promote antibiotic stewardship practices among dental providers in the state. We provided trainings to children's special healthcare needs care coordinators, and we are incorporating the dental kits and like toothbrushes and testing materials into their specialized care package to promote awareness of oral health. We collaborated with Maximum Health to make videos for training the big staff, and we are also in the process of updating our clinical guidance, like revising routine lead apron use during dental x-rays, aligning policy with national safety guidelines. We want to make oral health part of everyday life, not just the dental chair. So we are collaborating with Planet Smile and coming with a hands-on immersive dental symposium for middle and high school students to mitigate the shortage of oral health providers throughout early engagement. We are also empowering certified nursing assistants, and we are collaborating with the long-term care facilities to improve oral health outcomes for vulnerable population in the long-term care and home care settings. We also collaborated with HIV, gave presentations, and we are in the process of making bookmarks and distribute bookmarks and oral health kits to the HIV population. We are also working with incorporating oral health through our maternal, infant, and early childhood home visiting program. And we also applied for Title V funding to develop oral health features in the Healthy Tomorrow app and support a teledentistry pilot project in the Marion County. So, in the Department of Health, our work is guided by our 4 pillars, which is we are maintaining or making a culture of prevention and collaboration. We serve our communities with empathy. We hold our work to high standards, and we plant the seeds for long-term prevention and care. Oral health is the gateway to our overall health. While working together, we are building a stronger, healthier Indiana, one smile at a time. Thank you.
Any questions? Thank you very much.
Thank you. I have a question. Is all the water in Indiana fluoridated?
Great question. So till 2-3 years back, 91% of the Indiana community were water fluoridated. But with the recent changes which are going on in the state, many of the communities have decided not to fluoridate their water.
I was afraid of. Well, if you ever want somebody to speak to why it's important, I grew up in a community that refused fluoridated water. And it wasn't until I was an adult that I found out it was because of the company that makes the cider did not want anything added to the water. Our dentists had a horrible time. I probably had fillings in every single tooth and have had multiple root canals. Now the water is fluoridated, but it was Martinelli cider that just did not want anything added to the water. And there was no natural fluoride in the water, and it makes a big difference.
I do have to point out that Nellie is a team of 2, essentially, 1.5, right, people. And all of this that she just presented to you has been accomplished in, is it 3 years that you've been in that role? Yeah. It's amazing. And it is, I mean, she's like the poster child for bringing in partners, this is for your notes, Michelle. Bringing in partners, looking for every dollar and cent because she doesn't have money to like put out, right? So she has to find all of it. And then working collaboratively with all of these different organizations and leaders, and it's really remarkable. And you can hear the passion in her voice for this space right now.
And thanks for the collaborations we have made and so eager to do the work in Indiana.
And I want to second that. I've been in the School of Dentistry for many years, and I have seen someone so dedicated, and she has really levered up everything in terms of our health.
Thank you.
Thank you very much. That comes to the bottom of my agenda. Is there any more business to come before the executive committee today? Seeing none, I'll adjourn the meeting. That doesn't require a vote, though.
I'll make a
We're adjourned.
You know, what I hear.
Now I'm beginning to start my